Good evening, everybody. Those who have joined from India. Shital, it's good morning for you. And people who have joined from all over the world, it's sharp 8 p.m. Some people call this as Indian Standard Time. We call it as IFICS Standard Time. We always start on time. And there is no guarantee that we'll end on time. It will all depend on the questions you're going to ask. So welcome everybody. Welcome to Dipti Patankar, wife of late Dr. Joy Patankar, who was inspiration for starting this conference called IFICS. Dipti is among us, and this is a moment to remember Joy. I request Dr. Sandeep Patwardhan, the pillar. There are 4 pillars of IFICS, and he's one of them, to welcome everybody and get this historical meeting started. Sandeep, over to you.
Hi, Taral. Thank you very much. Good evening, and everybody who's joined in for this extra session of IFICS. A very, very warm welcome from IFICS. So IFICS was really a kida or a thought which was instilled in our brain by Professor K. Wilkins a long time ago. He came to India in 2000 and taught us about pediatric fractures. And then we realized that there is really nothing in India that trains consultants as well as residents the finer nuances of how to treat children's fractures in a more effective way. So we started this concept and we wanted a catchy name. So I remember Taral and I sitting in my balcony and saying that, what should we call it? So we were thinking of all kinds of acronyms, but we wanted something that said IFICS. So it became International Fractures in Children Symposium. And it's grown from pillar to pillar and gone from strength to strength, courtesy a very big international pillar, Shital Parikh. Because of Shital, the momentum just kept on increasing and the stone just kept on rolling down. And this is, I think, the 7th or 8th year that we are conducting IFICS. And we had really planned a really big meeting in Pune in September this year. But because of COVID, we've all been forced and confined to our homes. But we thought that in the true principle of teaching, which has been instilled into us by the late Dr. Joy Patankar, as well as Professor Wilkins, the teaching must go on and the show cannot stop. So we decided that we must go on a web platform, make it as creative as possible, as interactive as possible, and as international as possible. So we are happy to announce that we have more than 250 delegates from all corners of the world: Middle East, Southeast Asia, USA, UK, and India, and Southeast Asia, Sri Lanka, Nepal, Bangladesh. We have people from everywhere. We have seniors, we have our teachers, we have our mentors who are logging in to listen to these programs. Dr. Tanna is here, Dr. Mukhi is here, Dr. Kakatkar will be here. And we have this excellent IT generation, the technology whiz kids, Ashok, Shyam, and Neeraj, Bijlani, who are helping us conduct this. And of course, the smoothness with which Vama Events and Vikram Patwardhan helps us every year to conduct this meeting is really remarkable. So welcome all again, and let us kick off this first introductory webinar of IFICS 2020 by starting with talks on bone remodeling and is it a fracture by Shital. But before that, this is a new platform and we are all yet novices and are getting used to interacting with each other on a web-based platform. And there are a lot of tips and tricks that you need to learn. So I will hand over for the next few minutes to Ashok and Neeraj so that they can tell all the attendees as well as the faculty and panelists that how this webinar is going to work, how the quiz works, how the interaction goes, and how to make it as smooth as possible without any time lag or delays. Over to you.
So Neeraj, we are not able to hear you.
Yeah. So all of you must have received this message via email. And if you have not received that, that means you have not joined here. Anyways, so this is the message which you will be receiving every weekend which will have a direct link on which you click and you will be taken to a website of which is called zoom.us, this website. And after that, you will need to install an app. This is preferably advisable to seen on a laptop. And when you go to this website, www.zoom.us, there'll be something called as resources. And then you'll have to download the Zoom Meetings app. And once installed in on your laptop, you will get this window here. And you will have to sign in. Preferably sign in using Google account or the same email address which you have given us on IFICS, so that you can join in very smoothly, and keep the name also same when you're installing it. So as is, there is an easy option, sign in with Google. So you don't need to remember the password. And to change your name or anything which you need to do, on the right side, there is a circle if you see on the window after signing in, where my photo is seen. You will get you may get blank here or some diagram here where you can change it to your photo preferably. And you can go into your settings and you can change your name if you want. For smartphone, iPad and tab users, we do not recommend these devices, but in case you don't have a laptop or computer easily accessible, you download the Zoom Cloud Meetings app from the App Store or the Play Store. And same way, sign in that app using the same email address registered with IFICS. This is very important. If you sign in, only then you will be able to take the full advantage of this, and we will be able to allow you inside. What is most important is we are going to have some polls and quizzes. So do participate in that. There is a Q&A box which you can see at the bottom. So if you want to ask any question and answers to the speakers, you can ask in that and the moderators will take it up. And most important is that enjoy the web experience. And besides that, for the post IFICS conference, or as the month goes on of the whole month, we have two things for you. One is a Telegram group for interactive discussion, which will be sending the link here in the chat box for those who have not received. And there is a WhatsApp group for basically communication regarding Zoom links will also be sent besides your email address. And if you want, you keep yourself muted and your video off. When you want to speak, you can raise your hand or you can ask a question and the moderator may allow you, depending on the time, to allow you to speak to the speakers. And that's how. And for those who have not registered on IFICS and are listening to this webinar on OrthoTV platform, they still have a chance to register for the main conference, which is starting this weekend, Saturday. So you can contact these phone numbers or you can write on this email address and still register for a very nominal rate. So I hand over to my partner, Dr. Ashok Shyam, to continue and tell you more about this.
I think I'll speak with Mandar. Currently,
Okay.
I think Dr. Taral will be taking over.
Okay.
Yes.
So thanks, Neeraj and Ashok, for doing that. So one more person who's been, supportive of IFICS and always been part of IFICS family is Vama Events, Vikram. A few words from you. A wonderful work done in a very short time on registration, replying to all the mails, sending mails, all the links. So, Vikram, please spotlight Vikram and we can have a few words.
Good evening, everyone. Thank you, Dr. Taral, and thank you, Team IFICS, for partnering Vama as always. It's indeed a privilege to be part of the IFICS family. I would like to take this opportunity to welcome all delegates from all across the globe who have registered for this wonderful and unique conference that has been planned over the next 4 weekends. For any delegates or any faculty, if you have any queries, any suggestions or any questions, then you can feel free to contact those 3 numbers of Vaibhav, Pallavi and Chaitra. And we would also be keeping the online link to register open for the next couple of days. And we would also continue to keep the link open at least till the 3rd week of September. So for friends and colleagues who have not yet registered and who wish to register, the link will be open. Please feel free to call any one of us and we would be happy to assist you with any queries or any assistance that you might require. Thank you and have a wonderful time for IFICS.
Absolutely, Vikram. So people who are going to join later on, they can still have the full fun of IFICS because it's going to spread over a whole month. And if they have missed a session, they can listen to the recorded session and still join up. So any one of you, if you are busy in emergency surgery, Ifix Treasury will be there and you can still look back at the missed lectures and attend that. So that's how this conference is absolutely different. So let's get back to the business of learning. And I want to invite Dr. Premal Naik from Ahmedabad first to talk to us about remodeling. Premal, again, part of the four of us who started IFICS, and he's going to talk to us about remodeling of fractures in children. Premal, over to you.
So it is said that extraordinary circumstances required extraordinary solutions, and here we are with online IFICS. As Sandeep told you that we had planned a grand meeting in Pune, but we couldn't do it, but we are still here with the learning. So let's go through a unique aspect of pediatric skeleton, which is remodeling of fracture. So basically, if you remember a movie called Curious Case of Benjamin Button, basically this was a movie in which a protagonist is born old, and as the time grows, the protagonist basically becomes young. And that is how the story goes. Remodeling is very curious phenomenon, just like that. So if you understand the fracture healing basically has a 3 stage. The first stage is inflammatory, in which there is a hematoma formation and it organizes into a thick hematoma. The reparative stage, hematoma is first invaded by cartilaginous strain, and then it is converted into soft and then hard callus. And it is the remodeling stage which comes the last, and this is one of the best thing which happens in the children. We all know that the remodeling potential is highest in the infant, and as the age progresses, the remodeling potential decreases. So this basic phenomenon has a very unique aspect for remodeling in children. It is a remodeling capacity of the malunited fractures in the children, which encourages all of us to practice close techniques for treating fractures in the children. But we must remember that bone remodeling processes are not limited to fractures, but it undergoes to variable degree and remains active during the person's entire life. And due to this homeostatic activity of remodeling process, the bone has its own dimension and structure of a healthy bone. So before I proceed further, let me just check your knowledge of what remodeling means to you. Let me give you a situation of 3-year-old female with a 1-week displaced distal line radius fracture and 6-year-old male having 1-week old fracture radius ulnar. Ashok, would you please begin the polling? Okay, so what will you do in this cases? Your option 1 is you will conserve bone because you think it will remodel. You will re-reduce both as this cannot remodel. You will accept the distal radius but not accept the radius ulnar fracture. And you will not accept the radius ulnar, but you will not accept the distal radius.
So Premal will wait. Everybody is voting, and we want to see 100% people voting. We have reached 33 out of 123, and it's a very close contest. I'm going to announce the results soon, Premal. So 2 seconds more, and we are going to end polling. So please.
The panelists can also vote.
Okay, so majority of the people say that conserve both and they are likely to remodel. Okay, so what we'll do is as we go further, we'll learn whether both of them did remodel or one of them did not. So whenever it comes to remodeling, we do not understand where actually does this take place. So basically, if you look at an example of this neonatal fracture, this patient came to me about a 1 week down the line, and this is the best position I could get with use of Paulic harness. This went on to unexpected, very good, as expected, very good healing. This is 3 months follow-up. This is 1 year follow-up. and this is the follow-up at 5 years. If you note in the circle that there is some telltale signs of malunion still there. So this tells us that 100% remodeling does not take place at the shaft level. So then we need to go back and to check where does this happen. In a landmark study by D.W. Murray, what they did is they made a transverse osteotomy in a leg of rabbit and held it in angulation till it healed with a plate and then measured the bone alignment in length. What they found was that the angle between the joints changed rapidly and alignment of the limb improved, and they found that that was due to asymmetrical growth of the epiphyseal plate. But the angle at the fracture showed very slow improvement, and they called it as a bony drift. And calculation showed that it was insufficient to improve fracture angulation, as we have already seen in the last slide. So when they calculated the effect of growth plates as well as cortical drift, they found out that bone drift accounts only for 25% of the correction, while it is the epiphyseal growth which accounts for the 75% of the growth. And this is how the figure was arrived, and this is the values which we come at the different ends. In another study of human patients, 28 patients were studied by Murray et al. They were all patients with malunited femoral fracture, and when they measured remodeling at the proximal and distal physis as well as femoral shaft. They also found that 75% of the correction occurred at the physis and only 26% at the fracture site. And they found that younger children remodeled better than older children. So all these years, we all have learned about remodeling is the Wolff's law, which says forms follows the function. In 1892, Wolff said that the new bone is produced where it is mechanically necessary and it is reabsorbed where it is not needed. So in this manner, when the fracture consolidates in the angulation as shown here, new bone is formed, more bone forms on the concave side, and the bone is then taken away or reabsorbed from the convex side. But this accounts only for 25%, and so if only that has to happen, the deformity will be left behind. It was a study by Powells in 1975 where he studied physeal growth and pressure. What he studied and found out was when the growth cartilage is put in under pressure by selective growth, there is a different area of growth in the growth plate. So when there is an intermittent pressure within the limits of physiological stress and strain, it stimulates the growth plate to form a healthy bone. If you say that this law came only in 1975, then you are wrong. The similar law was already found out by two different gentlemen, Carl Hutter and Richard Walkman, and we knew it as a Hutter-Walkman law. According to them, in the skeletally immature bone, the growth is relatively inhibited in the area of the increased pressure and relatively stimulated in the area of the decreased pressure or tension. So to simplify their words, what I would like to say is the physis, which is adjacent to the malunited fracture, tends to realign perpendicular to the forces that act through them. This modifies the fracture's orientation with respect to the axis of the bone. But when there is a constant pathological strong pressure, it inhibits the enchondral growth. To understand this with a diagram, when you have a malunited fracture, the soft tissues on the convex side are stretched and periosteum and other soft tissue on the concave sides are relaxed. So when there is a loading of the joint, the concave side of growth plate is stimulated and forms more bone, and the convex side of the growth plate does not form that much bone, and that is how there is a realignment of the bone. And this physeal realignment accounts for basically 75% of the remodeling. So now let's look at this into a real life situation. This distal radius ulnar fracture was treated by this manner, and surgeon thought that the fractures have united, and he removed the fixator and allowed the child to mobilize. The child presented to me in this fashion. So if you want to see what is happening here, this is known as a cortical drift, which you see that already on the concave side there is an extra callus, and on the convex side the callus is less. What this cortical drift does, it just reduces the bony prominence. And if you look at here, the radius and ulnar physis are angulated in a different plane. So this does not really correct the joint angulation. What happens over the period is the physis itself reorients and it corrects the angulation, and therefore now you can see the radius and ulnar physis are aligned parallel, but there is still some angulation which is left and which tells you that there was a fracture in that situation. Since we are going to deliberate on each and every fracture over next 8 days, I'm not going to tell you what is the acceptable limit criteria in each fracture. Instead of that, I would just go through the laws which are affecting remodeling. And the first and the foremost is the age of the patient. As we have already seen that when you have a birth fracture and if it unites like this, within few months, it will become significantly clinically normal. Over the period of time, you will see that it straightens very well. You can see mild varus here, but at end of about 3 years, it's absolutely straight, but still there is some sign which will tell you that there was a fracture, as we have already seen in a 5-year follow-up earlier. But in a case when the child is older, like this 8-year-old boy who had a fracture shaft femur like this and had went into malunion, at about 2-year follow-up, the child had perfectly aligned proximal and distal femur, but there was a still significant angulation which was there at the fracture site. This does tell us that it is only the 25% of the cortical drift which could not correct the angulation, but still the physis, which accounts for 75% of the remodeling, has aligned themselves very well. So here the anatomical axis is not correct, but the mechanical axis is very well restored. Another law which affects remodeling is type of the displacement. Now let's look at the answer of the quiz. This is the first case. 2-year female had this type of fracture. After close reduction under general anesthesia, the position did not improve. On the 6th day, they came to me for second opinion. I said it is very comfortably I would be able to conserve this. So on the day I removed the plaster, I took an X-ray and found that there was no clinical deformity, and radiologically also the things were improving very, very well. It was just at the end of 5 weeks. And at 6 months, there is no signs of fracture and there is a complete remodeling. So basically, the translation is the thing which corrects almost 100% in most of the young children. So now let's see if you have a translation of the shaft, does it correct itself or not? Another patient, 2-year female, had a fracture shaft femur and she had the best possible reduction in the anesthesia like this by one of the senior orthopedic surgeons. The parents were very worried. So this child was sent to me for second opinion. On day 10, this was the position. This was about 1.5 to 2 centimeters of shortening, which I would not accept. But this was a perfectly nice alignment with bayonet apposition. At the time of union, they completely united in a bayonet position. At 9-month follow-up, most of the bayonet reduction had straightened out, and 1.5 years down the line, because the fracture was reduced very well, there is hardly any sign of fracture seen. So basically, translation corrects very well whether it is in the metaphyseal region or a diaphyseal region in children generally less than 10 years of age. Another law which affects remodeling is proximity of the fracture to the growing or non-growing end of the bone. This child with a head injury presented to me 10 days down the line. The child was unconscious and was on ventilator for 5 days before coming to me, and one of the orthopedic surgeons had advised him surgery. I said conservative treatment can easily be done. About 6 months down the line, you can fracture started aligning itself. About 7 or 8 months down the line, you can see that significant alignment has taken place, and this is a function of the same child. As a surprise to me, the child came back after 13 years with his uncle having a proximal humerus fracture, and at that point of time, the X-ray showed there was absolutely no signs of fracture in that humerus, and he had a normal shoulder function. Contrary to this, 2-year male patient had this type of supracondylar fracture which was treated conservatively. Unfortunately, it went into malunion and the child developed cubitus varus. Surprisingly, this child came back to me after 6 years with gross cubitus varus, and which has led to lateral condylar fracture, which Sandeep will tell you in Sunday's session what are the complications of cubitus varus following supracondylar fracture. So basically, another patient, a 7-year male, had very grossly displaced supracondylar fracture. Surgeon had done an excellent, very, very stable fixation, but he did not consider a good reduction as a prerequisite to fixation. So the child united in this position in which there was a posterior angulation as well as translation. In couple of months, the translation improved significantly, but still posterior angulation remained. And at 1 year follow-up, the posterior angulation also corrected. And that tells us that the fractures near the growing end of the bone remodel exceedingly well, and the angulation in the plane of the joint motion also remodels very well. Another law which affects remodeling is location of the fracture. This 10-year-old male had bilateral distal radius fracture. One side was epiphyseal, another was metaphyseal. The metaphyseal slide displaced on 10th postoperative day with 32-degree angulation. One of the surgeons they consulted had advised remanipulation and K-wire fixation. I could convince them to persist with the plaster. So on the day of removal of the plaster, we had 36 degree of angulations, which reduced to 27 degree at 7 months, and it completely corrected at 1 year follow-up with excellent functional results. So it tells us that the fracture near the growing end of the bone, along with the angulation in the plane of the adjacent joint, remodels very well, especially in the children less than 10 years of age. Now, let me give you the second example of the quiz. This 6-year-old male had this X-ray at the time of injury. The child was treated on an OPD basis with this step. Child presented to me on day 7 of this injury. And when I measured, the angulation was 24 degrees in radius and 12 degrees in ulna. As I know that this is not going to remodel, I advised them remanipulation under anesthesia and plaster, but the parents refused. This is it at the time of removal of the plaster, where the angulation increased to 30 degree, and this is 17-month follow-up, where the radius is still angulated to 20 degree, and there is mild restriction of the pronation, but he is functional, and parents are not worried about that. So this tells us that the diaphyseal fractures, which are away from the growing end of the bone, does not remodel well, because we know that it's a bony drift which corrects the shaft angulation, and it accounts only for 25% of the remodeling. Now let's look at the rotational malalignment correction, because it is traditionally believed that rotational malalignment does not correct at all. In a study by Buchholz, he reported 11 patients with fracture shaft femur who had some malunion in rotational alignment. He evaluated the overgrowth as well as rotational deformity with clinical examination and MRI. He found that mean overgrowth was 0.4 centimeter and maximum about 1.1 centimeter. He also noted that anteversion increased by 12 degree in few patients. So all these patients who had difference of anteversion more than 10 degree had repeat MRI after 4 years. What he found that mean anteversion difference diminished from 15 degree to 7.5 degree. 3 out of 5 children, it became normal. Only the oldest child in the series did not show any improvement. So rotational malalignment also can correct slightly, but cannot correct completely. And we have to take rotational malalignment seriously whenever we are dealing with fracture reduction. Another interesting phenomenon is the overgrowth following a fracture and close reduction in children. This is especially true in femur. Though radius ulna, humerus, and tibia all elongate, but they do not elongate as much as it happens in femur. So in this study by Nordin, they studied 62 children. 61.2% had shortening of more than 1 centimeter at the time of union, but 1/3 of them maintained the shortening at the final follow-up. 2/3 of them had significant correction in first 18 months of the follow-up. The average overgrowth was 1.17 centimeter, maximum overgrowth was 2.5 centimeter. Overgrowth was found to be maximum in children with proximal third fracture. Sex, morphology of fracture, or side of the fracture did not have any influence on the overgrowth. So they say that the children less than 8 years have higher capability to correct limb length discrepancy, and after 8 years, you should not accept any shortening. Coming to the end, what things we need to remember before we move on to our journey of IFICS is a few principles which relate to remodeling. Basically, the remodeling is best when the child is young, fracture site is closer to the growing crisis, and when angulation is in the plane of motion of the joint, especially when you are talking about the hinge joints. The rotational deformities usually do not correct spontaneously, and any shortening more than 1 to 1.5 centimeter in fracture shaft femur is less likely to, and that will be this in the session of the femur fracture. With this, I would like to end. And with the hope that we find out some gene which takes us to the journey of curious case of Benjamin Button, and we all become again young like this. This is a photo from 50-year back fracture a symposium that happened in my city with all the friends. Thank you very much for your kind attention.
Okay, so thanks, Premal. Please unshare your screen. And as I invite the next speaker, Dr. Shital Parikh from Cincinnati, to talk to us on is it fracture? It's a common question. When we see a child who doesn't have a fracture, it may look like a fracture. Child has a fracture and we can't see where is the fracture. So as we will, Shital is preparing. Just one question I want to ask Premal. There is a question from audience. Is that this remodeling process, is it also applied to congenital deformities such as posteromedial bowing of tibia? We see it happening only in fractures, but will it also apply to other conditions?
The answer is absolutely no, barring the exceptions like posteromedial bowing. Posteromedial bowing has a natural tendency to correct, and it does not correct uniformly well in all the patients. So I have many patients who have exceedingly corrected almost to neutral, and I have seen few patients who haven't corrected at all. So I don't think the remodeling process has anything to do with congenital deformities. It is strictly post-traumatic deformities, or maybe post-infectious deformities to an extent.
Absolutely. There are some more questions we'll take after Shital's talk. So Shital, please start your talk on is it a fracture? Thanks.
Okay. Can you hear me, Taral?
Very well. Loud and clear. Yeah.
Okay. So we'll get started, and you can see my slides as well.
Yes.
Yes.
Okay.
All good.
All right. So we are going to talk about some variations in pediatric skeleton, and the outline is we're going to look at some radiographic variants. What is normal in kids? What is abnormal in adults? And then is there a hole in the bone normal? And then the pitfalls in radiographic interpretation. So we start with acknowledging the German physicist Röntgen, who first invented X-rays, and this is the X-ray of his wife in 1895. So since then, we were able to look at the bone, and there has been significant advancement. When you come to infants, there is periostitis of infants usually seen in the first 6 months. And when you take an X-ray, you would see a lot of periosteal growth or linear periosteal reaction along the long bones. And this is normal. This is normal for the infant. There have been studies that have shown it's more common in tibia compared to the other bones, but it's also seen in all other long bones. So you want to make sure that you don't call it a fracture, because a fracture would also heal with significant periosteal reaction. So this is normal in neonates. The abnormal periosteal reaction would be when it's focal, when it's in certain areas, and when you have clinical symptoms along that area, then it would be a fracture. Otherwise, you're looking at normal periostitis of infancy. When you look at the cervical spine, there are significant variations. In itself, it could be a lecture just to look at the variations in the spine. But if you look at the C2 and the spinal laminar line, you can see that it normally has to touch, but in kids, it may not touch. Like on the right side, you can see that the C2 lamina is not touching the spinous process is not touching the spinal laminar line. If you look at the pediatric C-spine X-ray, you may see this subluxation of C2 over C3, and that's a pseudo subluxation. It's not true. You have to look at the spinal laminar line, which is on the back side, and if that is intact, then this is a normal variation. It's just a pseudo subluxation. Similarly, the pre-vertebral soft tissues, you have an increased soft tissue, especially if the child is crying. You see more soft tissue in the pre-vertebral area, and in children that the atlantodense interval is also a little bit more. It's 5 because it's not ossified, and you can see where the yellow arrow is pointing is where there is an ossification for the dens. So it's not a fracture, it's at the base of the dens, and this is normal for a child. We'll see more pre-vertebral soft tissues in children compared to adults. There are incomplete fusion of the secondary ossification centers. You'll see them in the midline and mainly in the posterior structures. The borders of these incomplete fusions, they are smooth and sclerotic compared to fractures, which are a little bit jagged and not sclerotic. But these are different examples of normal variants of vertebral development. You have some rings, which are the epiphyses on top of the end plates. And if you look at the ossification pattern, below is an example of a 10-year-old girl, and you can see in 4 years that epiphysis would gradually fuse to the end plate. So if you see someone at this age and you see this small flake of bone on the anterior aspect, it is not a fracture, it's just the ring epiphysis. Similarly, wedging, we are frequently consulted for wedging after road traffic accidents or fall from height. And it is a difficult thing, especially in a kid with other multiple injuries. You may not be able to have point tenderness or symptoms. So the way to diagnose it on the X-ray is to look at the amount of wedging, and it's considered to be significant wedging if it's more than 20%. If it's less than 20%, it's considered to be physiologic. The other thing you want to look at is that the end plate here is pretty straight, whereas in a normal bone, you will have a little bit of convexity of the end plates you can see on both sides. So even though there is anterior wedging, this convexity on both sides would tell you that this is a normal vertebra. If you look at the vertebra below it, you can appreciate the convexity a little bit more. Versus when you have a fracture, there is flattening of the end plates when there is wedging. So that's how you can differentiate. Here you can also see like two double cortical lines, which is usually a fracture in a healing stage when you see some reaction like that. You also need to know the normal ossification sequence, especially around the elbow, so you can make your own mnemonic. But one of them is the crito, which is, it starts with capitulum as the first ossification center, then the radial head, then medial epicondyle, then trochlea, olecranon, and the lateral epicondyle. So that's a pretty predictable sequence with about 1.5 to 2 years between each center. So the important thing to know here is that when you have a fracture and you're not really sure, if you know the order of ossification, it would help you. For example, this is a patient that was seen in our hospital just last month. The resident saw this patient at night and discharged the patient, saying that he thought that this was the trochlear ossification center. How do you know that is this trochlear ossification center or not? Is if you go back and look at your sequence, you see that the trochlear ossification center ossifies at around 8 or 9 years of age here, and the medial epicondyle ossifies before that. 4 years before your trochlear ossification center is medial epicondyle. So now you go back and look at the X-ray. If you say that you have a trochlear ossification center, then you should have a medial epicondyle center even before the trochlear ossification center. So this is actually a medial epicondyle fragment that is incarcerated in the joint, and it's not a trochlear ossification center. So this patient was called back the following day, and the medial epicondyle fracture was fixed. But knowing the order of or the sequence of ossification would help you in your diagnosis. There can be irregular ossification, especially around the trochlea. It could be irregular, and sometimes you may think that there is some crush in that area or fractures in the area. If you look on the lateral view, it may look like there is a loose body, but that's a trochlear ossification center, which is irregular. Other patterns, you can see that there is a small cleft here in the radial head. That's not a fracture. This patient had no injury. This was an incidental finding. Similarly, you can see some notching of the epiphysis that is also considered to be normal. But you can pretty much diagnose this as a fracture if you have an injury in that area and you're looking at the X-ray. So you need to be careful about patterns of ossification. Sometimes the comparative X-ray would help when in doubt, and I do get those at times, especially if the family really wants to know whether the patient has a fracture or not. Otherwise, if the patient is symptomatic and you immobilize them for 2 or 3 weeks, it would heal even if there is no true fracture, if they are symptomatic and have an injury in that area. So if it's not going to change the treatment too much, then sometimes we would just mention that it looks like there may be a fracture or there may be an occult fracture. We're not really sure about it. But if it's going to make a difference to your treatment, then getting a comparative X-ray or doing further imaging like an MRI, ultrasound may help you to know exactly if you are dealing with a fracture or not. Trochlea, we already saw those irregular ossification. Same way with the olecranon, this patient was told that they had an olecranon fracture, whereas the opposite side had a similar olecranon apophysis, So it can be variable. You can see more ossicles, you can see widening either on the volar side or the dorsal side. As far as the capitulum, the physis of the capitulum is usually wider posteriorly compared to the anterior portion of the physis. You need to be careful and not diagnose this as a separation from the backside. You can see several ossicles in the olecranon as it ossifies, and it may appear to be a fracture when you have an injury in that area. But again, the borders are a little bit smoother and a little bit sclerotic compared to an acute scenario. When we see knee injuries, there is always a confusion whether this is an OCD or whether this is an irregular ossification. There have been several studies that have looked at it. And one thing is that if you have a younger patient, typically less than 8 years of age, by default, it's going to be irregular ossification. And if you have someone who is older than 11 years of age, by default, it's an OCD. But there is a gray area between those ages, 8 and 11 years of age, when you're not really sure whether it's a OCD or whether it's a irregular ossification. And one thing you can do is do serial X-rays to find out. If it's irregular ossification, it will progressively get better compared to an OCD, which would get worse over time if not treated. The lateral epicondyle, there is a very small time frame when you'll be seeing lateral epicondyle ossification center. May appear to be a fracture when you see it, and when you have an injury in that area, just to know that there's an ossification. The proximal humerus epiphysis may appear to be a little bit, irregular, sometimes a little bit sclerotic and in patches, and you need to know that's normal. Patella, you can see this is a normal patella on the left and osteomyelitis patella on the right. They don't look a whole lot different except for the soft tissues around it. And of course, taking clinical scenario into your decision making is the key here. You have a lot of epiphyseal variants, like you see the distal ulna here is notched, and you can have a deeper notch or even a cleft in that area, and that's not a fracture. You can see some spurs at the end in the epiphysis, and I've seen residents diagnosing this as fractures in this area, and you just need to know the normal sequence. You also need to know where the physes are located, like in the hand. The metacarpal physes are located distally, except for the first metacarpal when the physis is located proximally. And you should look at the variations. There are double epiphyses, that means epiphyses at each end. Pseudoepiphysis means it's trying to make an epiphysis, but it hasn't gone all the way through, and then notched epiphysis. They can be mistaken for fractures at acute setting. For example, in this patient, you can see that there are different levels of physeal variations in the proximal aspect of the metacarpal. Like one is almost like a double epiphysis, the second one or the third metacarpal is like a pseudoepiphysis, and then there is knot on the fifth metacarpal. And these are not fractures. So if you see these patients, these are just variations of the physis. Pseudoepiphysis can be a cleft. It can look like a delta phalanx at times. And if there is significant deformity, then you have to investigate further. But you can see this kind of attempt for the bone to make next epiphysis. As far as the shape is concerned, there are certain epiphyses which are wedge-shaped, especially at the distal tibia. And sometimes it can be confusing whether it's a tilo fracture or there is a fracture line going through, especially if you are evaluating the distal tibia on a leg x-ray, like a tibia x-ray. So make sure you have focused x-rays, which are ankle x-rays, to look at it. Otherwise, you may get fooled in thinking that this may be a fracture. You have the humps, you have the Poland's hump, which is around the medial aspect of the distal tibia, and fractures crossing this area, like a medial malleolus Salter 3 or 4, has significant high rates of growth arrest. It may have to do with the zones that are crossed when the fracture happens, but you have to be careful about the normal hump. Same in the radius, you have a hump in the radius as well. where the listed tubercle is. And then in proximal humerus, the physis is like tent shaped. So you may see one end of the physis towards you and the other end behind you may appear to be a fracture, but remember, these are not fractures. And if you look at different views of the shoulder, you can see that here it says this tent shape in exportation. It becomes a little bit flat when you have a neutral rotation. And then it's like a triangle when it's internally rotated. So different shapes of the physis depending on what view you're looking at. But because it is tent shaped or triangular shaped, you will see the superimposition of the ends on an AP X-ray, and it may appear to be a fracture when it's not. As far as the fifth metatarsal apophysis, you can see that the apophysis is oriented in line with the long bone. That means it's longitudinal, and that's normal. But if you have a transverse line going through the apophysis, then that's a fracture. So fracture line is transverse, apophyseal plane is longitudinal. So that way you can know whether there is a fracture. It's just normal variation. When you can't see a fracture, then you look at fat pads, especially around the elbow. There are three ways to look at it. One is the posterior fat pad sign. The second one is an anterior fat pad sign, and it could be classified as minimal or significant. So posterior fat pad sign is always abnormal. If you see a fat pad sign, that means that there is an occult injury, there is some capsule elevation, or the fat tissue is elevated and there is blood inside. On the anterior side, some fat pad or normal fat pad sign is normal. So it is not abnormal, but the amount of fat pad that you see on this X-ray, which is by the white arrows, it's called a sail sign. It's just like a sail on a boat, and that is abnormal if you have significant, hemarthrosis. And this patient had an MRI which showed the fracture. You don't need an MRI for these. It's just that this was part of the study. So this is another example. 14-year-old boy hit his leg against the wall while he was running. And you can see that there is a fracture on the backside. It appears to be very, very minimal, but when you have traumatic hemarthrosis, I would recommend getting an MRI just to look for intra-articular injuries. This patient, you can see the fracture line well here. The issue with this fracture is that it may have started like a displaced fracture and may have reduced it, and I've seen it more than once, where you can injure the artery behind it. So you have to be very careful about, monitoring this patient for neurovascular as well as compartment syndrome with these injuries. As far as the accessory obstacles or the ossification centers, there are plenty of them. They are well-rounded, well-corticated, and some of the ones that cause some issues in diagnosis are the one at the end of the medial and the lateral malleolus. The os subtibiale, where there is an ossification center, it may appear to be a fracture of the medial malleolus when it's not. The os peroneum is another one that you can see here just at the base of the fifth metatarsal. Similar ossicles are seen at the end of the patella. These are just developmental or traction ossicles, and these are not treated as fractures. Now, this patient, just looking at the axial view, I was told has a fracture that needs to be fixed, but this is how all the bipartite patellas would appear. So if you look at the AP view, you can see that it's the superlateral quadrant of the patella. That's a bipartite patella, and it's a normal variant. This patient showed up in our clinic 2 years ago with pain around the dorsum of the foot, and was diagnosed as a navicular fracture. And if you've not seen it before, this is not a fracture. This is bipartite navicular. And this patient was seen in the clinic this week for his 2-year follow-up, where the bipartite navicular has almost healed. I think there is still some areas which are not healed, but it's almost healed. It was treated conservative. There are reports of requiring surgical treatment, just like you would need surgical treatment at times for bipartite patella. You may need it for the navicular as well, but this patient was treated conservative. When you look at the X-ray and you look at a patient next time, you would know that this is not a fracture because they all appeared the same way, bipartite navicular. Now, as far as the anatomic variants, you can sometimes see a spur in this area. You can also see a fracture through an osteochondroma or a spur like this, which doesn't mean that you have to treat it surgically. It's just that any spur can fracture. This was first described by John Struthers in 1% of the population. It's not an osteochondroma, which typically point away from the joint. This points towards the joint. And there can be a ligament of Struthers, and it's important to know that because there might be a compression of the nerve which travels underneath. A lot of times you would see some irregularity on the posterior medial side. This is where the big muscles are attaching, and these are normal irregularities. Don't confuse these with fractures. They are confused with malignancies at times, and MRIs are ordered for these. And I would just recommend to observe these, especially if the patient is not particularly symptomatic in this area. Another variant that we see normally for which MRIs are obtained are the dorsal defect of the patella. All these variants that happen in the patella are in the supralateral quadrant. So as long as there is a dorsal defect or a bipartite patella in the supralateral quadrant, I would not be too much excited about it, about treating it. You can skillfully neglect it and follow the patient. Like this patient has a dorsal defect of the patella, but it's in the supralateral quadrant, and those are where the variations are. Just like in a shoulder, your anterior superior quadrant is where all the variations are. Similarly, on the patella, it's the supralateral quadrant. As far as the deltoid insertion is concerned, you can see some fuzziness, periosteal thickening in that area. Similarly, where the interosseous membrane is attached, you can see a little bit of elevation or periosteal reaction at times. Also, you need to know how the nutrient channels look and make sure that you can differentiate them from, say, a toddler's fracture here. Most of the time, the nutrient foramens, you would see them only in the cortex. Are these loose bodies? So you can see that this olecranon ossification center on an AP view would appear as if there is a loose body in the fossa, and this is just an olecranon apophyseal center. Same way, medial epicondyle may appear to be a loose body, and sometimes it is, like the one on the right side is an incarcerated or at least a displaced medial epicondyle fracture. And once you reduce the elbow, you want to make sure that the fragment is outside the joint. And don't forget infection and tumors when you're dealing with trauma, because they can present with similar history. Here is a 10-year-old girl who came with an ankle injury, and she was treated conservative, and then 7 days post-injury, there was a consult for cellulitis of the ankle, and you can see the patient required multiple debridements. There was really bad staph infection, and it infected the calcaneus and the midfoot as well, along with the ankle joint. Multiple debridements, and this is 4 years post-op. The patient basically has a fused ankle, hindfoot, and midfoot. Similarly, you can see pathologic fractures here. This is a fracture, but is it a fracture through a normal bone, or is it through a UBC? When it's the proximal humerus, you need to be aware of where most of the pathologies are. Here is another patient, 6-year-old female, who was treated by my partner for a fracture because she had an injury, and the radiographic or the radiologist interpretation was a non-displaced metaphyseal fracture of the fibula. And then 5 weeks later, the patient came in my clinic, had this swelling. I had to consult my tumor surgeon and ended up getting a biopsy, and this was an osteosarcoma, and the patient ultimately underwent amputation. So just be careful about tumors and infection when you're dealing with fractures. Need to be aware of projection. Certain areas you can have lucency. It's also seen in calcaneus, where the triangle that you would find that it's loosened. So don't think that there is fracture or tumor in this area. Here is the proximal humerus with posterior dislocation. You can see the light bulb sign, and the intercondylar notch is also seen as lucency on X-rays. When you see deformity in two planes, then always assume that the deformity is worse than what you see on the two planes. Here is the lateral and the AP CT of a proximal humerus fracture, but you look at the oblique view and you can see the amount of displacement. So always make sure that always keep in mind that the deformity may be more than what you see on AP and lateral X-rays. You do need to differentiate child abuse, non-accidental trauma, very important. You can see these corner fractures or bucket handle fractures. They were used to be called pathognomic fractures for child abuse, but not anymore. They also see in metabolic disorders. So I will be careful. There have been a lot of legal issues trying to classify these fractures as child abuse or not. But as an orthopedic surgeon, our job is to just bring it to the attention to the social services that there might be a case for child abuse based on the patient's age, history, and fracture pattern. There are some fractures which are, highly specific for non-accidental trauma, like rib fractures or fractures in different stages of healing. But I've seen those even in child abuse situations. So you just need to be careful because the differential diagnosis for fragility fractures could be metabolic bone disorders, including hypophosphatemic rickets or nutritional rickets or other collagen and elastic disorders, which are osteogenesis imperfecta, Marfan syndrome, or Ehlers-Danlos syndrome. There have been recent, attention to Ehlers-Danlos syndrome. We have seen it very frequently. We have an Ehlers-Danlos clinic in our hospital, and this is a report of 72 infants whose parents were charged with child abuse when actually they had Ehlers-Danlos hypermobility syndrome and or vitamin D deficiency. So they were diagnosed or suspected of child abuse, but these infants then went on to have EDS or vitamin D deficiency. So even though you need to be aware of the differential diagnosis and you need to bring it to everyone's attention, also need to remember that it puts a significant burden on the family as well, especially if the family was not involved in the injury or in child abuse, and then they're accused of it. That's a significant liability. As far as lines and angles, I won't go in too much of detail. Just one patient here, like on the left side, how do you know whether this is a fracture or this is a dislocation? Well, you can see here very carefully, and you can see that there is a capitulum ossification center. And if the radiocapitular alignment is maintained and the ulnohumeral alignment is not maintained, then this has to be a transphyseal fracture, right? So if it's not aligned, like none of these two are aligned, if the ulnohumeral line and the radiocapitular lines are not aligned, then it's a dislocation, which is very rare in children. But if you can see in this situation where the radiocapitular relationship is okay, but the ulnohumeral relationship is altered, then this is a transphyseal fracture versus an elbow dislocation where both of the relationships are altered. So there are, if you want to look at it further, there are a couple of atlases which you can invest in. This is Keats and Anderson Atlas of normal variants that may simulate disease. And this is a very old atlas by my mentor, Dr. Crawford. I've got many mentors, and he's one of my pediatric orthopedic mentors. I would like to acknowledge him for all my pediatric knowledge that I've gained from him. So it may be worth trying to get one of these atlases. I thank you. I'll be ready for questions if you guys have any questions. Appreciate your time.
Thanks, Shital. That was an encyclopedic talk. And I'm sure when people have a confusion about fractures, all they need to do is just refer to this talk, forget the atlases. And you've covered a vast variety of lesions here. So time for some questions before we start with cases. So one of the questions coming from Chintan Doshi is that how do you differentiate the congenital issues with patella with acquired problems like osteochondritis dissecans? Especially it is on the articular surface, it can look the same. So what would you do then?
Well, you can hear me, right?
Yeah.
Yes.
See, the osteochondritis dissecans is a late process. It usually doesn't start in the preschool children. If you see an OCD, it's going to be in a little bit later age group. Usually, it would start maybe around 10, 11 years of age. Whereas, if you have a congenital thing, it will be much earlier. So one is by the age, and second, by its appearance. If you are in question, you can get an MRI because a lot of these dorsal defects on the articular side, they may even have a small pinhole, versus OCDs may have widespread cartilage issues. So the good thing is that the patellar OCD are not very common. Okay, so if the patient is not very symptomatic, you don't have too much of effusion or point tenderness, then a lot of those things, like if you have a dorsal defect or if you have a bipartite patella, those would be in the superlateral quadrant. So just the location of it would give you some clues as to the pathology.
And there's a comment for Premal from Dr. Slongo. Dr. Teddy Slongo is here. and you are saying that remodeling should be called as modeling because it doesn't happen again. So, to Dr. Slongo and Premal.
Can you hear me?
Yes.
Can you hear me?
Yes.
Yeah, more and more, when you go to the Wikipedia and all the textbook, remodeling is completely something different, but over decades, say always more remodeling. But now in the AO and in all our lectures, we have started to say modeling because this is a modeling and not a real remodeling, only from the sign of the word. So this is only a suggestion that because, what we should try with such events and educational events to bring the people forward, to bring new things. It makes no sense to repeat old fashions over decades, and overall, these two talks were fantastic, especially the last talk, a fracture or not fracture. I like it. It was fantastic. Yeah, this is really a big issue and a big problem. We see the correct X-ray and to know everything. So this is fantastic. But anyway, when we give talks, please, in the preparation, try to think about, is this really true, up to date? Or is it only old? I repeat a sentence over decades, always the same situation. This is only my input to the preparation. But it works very well. And have another question. I have seen both a lecture. They had this unique template. Should we use this template for our presentation or the private template?
Well, if it's easy to transition to the template, it will be great. If sometimes it doesn't transfer very well, in that case you can use your own, and if your institution allows you to use use the template, that the IFICS template, I think that would be better.
Okay.
So thank you, Dr. Slongo. A question for Premal is that, Premal, you said that rotational problems don't correct, they don't remodel. So should we accept rotation or try to correct it? What should we do? If there is when can you accept a rotational malunion?
So I think rotational malalignment will be discussed in each session. That's why I did not elaborate on that. Basically, what I mean to say is, if rotational malalignment corrects, only little part of it corrects. So it is advisable not to accept rotational malalignment beyond the prescribed limit, which will be discussed in each session. Hello? Did you hear, Taral?
Yeah, we must be careful that the sound is always perfect. Try to speak really to the micro. Otherwise, it's very, very bothering if you heard something far away. This is important. Otherwise, the delegates will go away.
So there was some issue with Premal. Can you repeat that? Talk a little louder so that everyone can hear.
Am I audible now?
Yes.
Hello?
Yes, Premal, we can hear you.
Yeah. So basically, what I'm trying to say is the rotational malalignment does not correct very well. And the limits of the acceptable rotation we'll be discussing in our sessions which are coming. So I think it's good that we wait for the sessions to end. And if that still the answer is not given, I'll give the answer. But rotation basically does not remodel as well as it happens in the coronal or sagittal plane. So we tend to accept as little mal rotation alignment as possible.
Okay. So let's move on. So Sandeep, I would request you to share your screen and present a case. Yeah.
Okay, can you see, Taral?
Yes, very well.
Okay, so we'll just run through few cases based on the talk from the audience as well as to the panelists. So this is something that we see from the NICU. A reference comes which says that we heard a snap when the baby was delivered, and this kind of X-ray is there. So Premal, if you can just say how would you treat this?
The best treatment of this would be just to strap that child and make the child painless. I would just body strap this fracture and expect excellent remodeling.
Right.
And
so
there won't be any clinical issues.
Neonatal birth trauma, especially long bone diaphyseal upper limb, after you rule out a brachial plexus injury, I think just arm to chest strapping using a simple micropore tape yields excellent results. And within 3 weeks of strapping, you can see enough amount of newborn formation, which remodels beautifully within a year. So a long bone like the humerus shouldn't be a big of a bother. But what about femur? So Ashok, can you put up the quiz? This is newborn, and I want all the attendees to give their option. Femur fracture, newborn, how will you treat it? Strapping, hip spica, Paulich harness, or none of the above?
It's an exercise for the fingers. Pull quickly. So last 5 seconds.
All right. So most of the people, 67% feel Paulich harness is a good way to do it. Strapping 16%, hip spica for a neonate 9%. And 8% feel none of the above. I don't know what is there in their mind. So let's go on. What happened to this child? This is another example of a neonatal femur, which was treated just in a slab. As somebody had said, none of the above. And question is, will it remodel? So Premal and Shital, do you think this neonatal fractures, we saw the humerus remodeled so beautifully. Does the same thing happen in femur?
Yes, Sandeep, I think this will beautifully remodel, but if you take an X-ray identical on either side, you will still see some telltale sign of angulation, but that shouldn't bother clinically at all.
Yeah, so, it would remodel. A lot of these fractures remodel, but the reason to get them a little bit aligned is because one is that, it would decrease the need for a lot of remodeling. The second is that families are always very anxious, and they see a deformity or when they see an X-ray. So I think it might be worth, trying to align it a little bit better. Now, we are not doing any treatment. The reason not to do a spica is because of, skin issues. You don't need it. But if you do a Paulich harness, what it does, it puts your, leg into a better functional position, like, flexion abduction.
Yes.
Especially at this level when the proximal fragment is flexed and abducted, it will try and align it a little bit better. So, even though it would remodel and a lot of fractures to remodel, we do end up, treating them. We try to reduce them. We try to get them a better alignment, just because we don't want too many deformities. We don't want the family to have so much of anxiety and then depend just on remodeling.
So basically, we will help the biology by repositioning and making the child comfortable.
Yeah, but sorry, for me, the first question here is not at this moment when we see the big callus and nearly healed, do we leave it alone or not? Because I know there are some surgeons, especially in Germany, they said, oh, we will not accept this in this way. And then they go at this stage, they go for a callus osteotomy and try to make it, to align it. But it's completely wrong, because we know at this time, this fracture, even it's looks not good, very good at the moment, can model. You agree? Can model. So the question is, don't touch it at this moment. Don't touch it.
Yes. Yes. So there's no need to do over treatment. But what I wanted to point out, this is after 1 year, Premal and Shital. So you can see here that the modeling has not really been very good. There's still a large amount of anterolateral bump which makes the family unhappy, as well as he started walking and the leg is short because of that bump. And this is the earlier child which was treated by a spica. So all those who wrote that they would give a spica, remember that the proximal fragment has the iliopsoas, abductors, and external rotators pulling the fragment into a deformity. And if you extend the leg, then you are accentuating the deformity rather than accommodating it. So you end up with deformity, which in these cases at least hasn't really remodeled. So whereas if you give a Paulik harness, then it aligns it pretty well in the direction. So it's important to align them. So Shital and Premal, what would you say? Why does this not really align? Why is it not modeling, as has been said?
So Sandeep, as I said that the shaft generally corrects by cortical drift, and cortical drift is basically accounts only for 25% of the remodeling. So even if you get perfect alignment of the physis and mechanical axis, you will still see some bend even in a neonatal fracture after for many years. So it may be a good idea, as you said, to align it reasonably well so that it comes into limits of remodeling and it remodels beautifully well. Because nowadays we need perfect bones for very demanding life.
Right. So we should not rely on modeling or remodeling. We must try to align it as best as possible to reduce the load on biology. I think that is the solution. Now, again, Shital, this is what you pointed out, a transfascial separation, which heals. I wanted your opinion, and maybe Dr. Shlongo also to comment whether a transfascial separation models well or it ends up with cubitus varus.
We have not a lot of such cases, but we have some cases. And mostly what happens is that you never see this fascial separation initially. Mostly you see it when the swelling you have a swelling in the elbow after 3-5 days. And in this age group, after 5 days, really we have some callus and that the separation is stiff. So the message is, if you have a separation, don't touch it, because really here we see a good modeling capacity because the joint is intact. The worst thing is if at this time in a newborn baby, you try to reuse it, you damage more, you destroy more than you help. This is my message.
Okay, Shital?
Yeah, we see this acutely, when the patient had an injury, a newborn, we have seen quite a few of these. So we would treat it like a supracondylar fracture. You want to prevent varus, so you can look at the arm like clinically. If there is no significant displacement or deformity, you can allow it to heal. But if there is varus and if there is a doubt, if you're not really sure, you can do an arthrogram, and that would show you, the arthrogram would also be required when you want to pin it. So you hardly ever have to pin this because their healing potential is very good, and you can put them, in a slab or a cast, and it would heal. But if they present acutely and they have a deformity, then they would behave like a supracondylar fracture. So I would reduce and pin it, and we have done it on occasions. It's not very common, but you don't expect cubitus varus to remodel too much. In a neonate, it might in the first year, but you can't rely on it.
Yes. So again, bringing back to the same point, the patients usually present late. They are already healing in 5 days, as Dr. Shlongo said. And but they don't remodel perfectly, and they do end up with varus, which might need treatment in the future.
Yeah, but again, I will warn to manipulate this fracture after 3-5 days. Then you damage more.
Yes. So late treatment, you leave them alone, accept it, and treat them later if there's a deformity.
Exactly.
Okay. Another quiz for everybody. A 5-year-old male, a 3-week-old injury, comes to you from your colleague for a second opinion. This is the X-ray. What are your options? Will you do an osteoclasis and recast this? Are you going to do an open reduction and plating looking at the encroachment on the interosseous space? Are you going to do a nailing, or you will just leave it alone, it will remodel? Ashok, can you put up the quiz?
So we don't have this quiz.
Okay. For me, it's clear. Leave it alone.
Leave it
Don't touch
alone.
It's the same as
Experience.
before.
Okay, Shital?
Yeah, leave it alone, but I would recommend to get good X-rays though, because I mean it's difficult sometimes in an injury situation to get perfect X-rays, but better X-rays would help you to define the angulation better. I'm going to leave it alone. I'm just saying for this and for other fractures to get good orthogonal views to look at the fracture in two opposite planes, 90 degrees, would be helpful.
So you take a third X-ray in an oblique plane too, because sometimes the deformity itself creates a wrong impression.
Yeah, I agree. But what is the effect of an additional X-ray? You know, it's a 3
We can't hear you.
Old injury.
Yes.
It's not healed, and anyway, you have to wait. Again,
yes.
I would not touch this fracture at this moment. You will destroy more. But what we have to discuss here for the delegates then is, if we have the same fracture and the same angulation in the proximal third, then we should correct it, because Peter Schmittenbecker made a good investigation. The deformity in the proximal third of the forearm does not is very bad.
It doesn't behave the same.
Yeah.
Yes. So if you remember the Premal stock, the age is in our favor. He's just 5 years old, and it's in the distal third close to the joint. So it's worthwhile waiting. And that is what we did. At 6 weeks, this is how it looked. And at 4.5 months, that was the complete remodeling with a really good cosmesis as well as function for this young child. So beautiful modeling here, and things went very well. Do you have a quiz for this, Ashok?
No,
Ashok?
Yeah.
So 13-year-old boy who had a clavicle fracture which was impinging on the skin there, and an adolescent boy, I'm sure Shital, a lot of people would plate this. So the options are, would you nail it, RJ strapping, open plating, or closed K wires? Five seconds more. All right. And what do the audience say? Oh, 74% are in favor of Robert Jones strapping. Just 8% want to plate it, 13% want to reduce and pass K-wires, and elastic nail 6%. So let's see how I treated this. So as with the majority, we went ahead and just did a conservative treatment. Robert Jones strapping, that is at 3 months. And that is at 6 months. It healed beautifully with no residual bump, defect, or any kind of functional limitation. Shital, you want to say something? Because the trend for plating adolescent clavicles, especially if they are tenting or in the lateral third.
Yeah, so I chose plating for this patient.
Yeah.
One is that, so I would, if you had not said that the skin was tenting, I would have treated it just like you did. My issue with the tenting of the skin with a pointed fragment, I've seen fractures turn to an open fracture over a period of time because of necrosis of the skin. So I don't know what you mean by, you can always palpate the ends of the fracture from the skin. That's not tenting. Tenting to me is, it has gone through the subcutaneous tissue and it's just one cell away from breaking through the skin. In that situation, I would try to reduce it. I don't have any experience with IM nailing or K-wires for clavicle fractures, but I would be strongly advised not to use K-wires because of migration issues. If you want to do something, I would recommend that you do a plate or nail, whichever your preference is. I'm not too picky on it, but the only indication is that, and then the second thing about the bump that you said, the bump typically would not remodel at 13 years of age. So you need to tell the patient up front that you are going to have a bump and it would not remodel. But that's, if you tell them upfront, then it's going to be fine. You just need to tell all patients, especially girls, after 10 years of age, the bump is going to be there.
Okay. Dr. Shlongo?
Partially, I agree with this. But again, first point, when we go back to the fracture pattern in this lateral clavicle fracture is completely different from an adult. The adult, I agree, you have to make a plate. But here we have a splitted periosteum and the clavicle comes out in this way. And the only point, if the skin is a problem, I make a small incision and bring the fragment back in the sleeve of the periosteum. But it's completely different from adult. Therefore, really, at least minimal invasive open reduction to bring it back in the periosteum sleeve, or nothing, depending from the skin. But I would never go in a 13-year-old, and this is not recommended from pediatric trauma surgeons to plate such a fracture. It's not recommended.
So for all the delegates, it's a very important point that in children, an open reduction to improve alignment does not always mean an implant has to be put in. You can better the alignment and remove the soft tissue and still conserve it. Is that right, Dr. Shlongo?
Exactly. When you look, the best illustration about all this fracture is in K. Wilkins Rockwood textbook. There are fantastic drawings inside here about this fracture.
Okay, thank you. So this is the last case that I wanted to share with you. A 9-year-old boy with a discharging sinus and a small sequestrum with a deformed wrist and overgrown ulna. So do we have a quiz for this, Ashok? No, I don't think so. So Premal, what would you do? Do you think this will remodel or it's going to need something?
I think, Sandeep, I don't think the infection will remodel exactly the same way as the trauma, because you have a healthy physeal plate. Here we cannot comment on what is the status of the distal radial physeal plate. So I think I'll reserve my opinion till I do more imaging.
Okay. So this was approached by cleaning up the infection, debridement, and we just waited and gave antibiotics as per culture. And I expected, because the child was 8 years old, that there will be a physeal bar and we will think of what to do. But if you look at serial X-rays, to my surprise, the growth actually was quite good and the radius kept on growing and the infection got controlled and the length also came back. So don't be surprised about remodeling of the physeal when there is hypervascularity, provided there is no bar across the physeal. A metaphyseal infection can also remodel. This is an example to just show that. Taral, I think you also have a similar case.
I have similar cases, and the positive effect is that the infection and the operation stimulates growing now, and therefore the radius grows more than the ulna, and we have the equal lengths. And this is a fantastic case, really. This is a fantastic case.
Taral, I am just stopping sharing my screen now. That was my last case.
Okay. And I have to stop the presentation because you plan to make 1 hour. It's a short session that we learn to that we see how it works and how it functions, and it works very well. And thank you very much. And we will see what happens for the 4 weekends in September.
Absolutely. So it's almost 9:24 now, and everyone has been here. This was supposed to be 1 hour session, but I'm very happy to see that everybody's here and listening to these wonderful talks and wonderful cases. I think it's time to wind up. In India, it's almost 9:30. All wives are waiting for dinner to get over, and husbands to do the dishes because it's pandemic time and
still lockdown.
So, we'll end the clinical session. This was an introductory session. Absolutely. This was unplanned, but we said, let's people have flavor of what IFICS is. And this has been relayed live on Ortho TV. So people who are watching this on Ortho TV, if you feel that if you want to register for IFICS, it's very simple. Go to www.ifix.in and register online. It's as simple as that. So with this, I have two announcements to make. The IFICS is not only these live sessions and cases and lectures, it is much more than that. And to tell you about what more is coming in IFICS, there are two young people here. So first I want to request Mandar to speak about Ifix Treasury.
Thank you, sir. Are you able to see my screen, sir?
Yes.
Yeah, so this is something new which we have planned, which is something known as Ifix Treasury. And so it's, as the sir said, IFICS is not just few lectures which will be there for a few weekends. This will be an online repository of knowledge which anyone can access. This was the team IFICS, all four of them guided me for making this, and more than 50 people have contributed to this IFICS Treasury. So what exactly is it? Basically, it has three components. Every session will have an IFICS video lecture where each lecture is going to be discussed.
Mandar, are you talking?
He's lost in the treasure, probably. So, so basically, what we're going to say is this is IFICS Treasury is effort of a lot of people. Mandar, if you can hear, yeah.
Hello.
You can live, yeah.
I'm sorry.
Yes.
Yeah. So sorry for the connection. So this is basically has three sections. One is video lectures about the basics of all fractures. There will be IFICS review articles where all the latest articles will be discussed, and there will be a small infographic PDF which you can use a print and keep it in your OPD for easy reference. So just like this, there will be the first session which will be on physeal injuries. We have got fantastic lectures which have already been recorded, and you can access this. And the way to access this will be discussed by Dr. Ashok Shyam from Ortho TV. Ashok.
So hi everybody. So IFIX Treasury is now will be available from tonight on Ortho TV and will be accessible to all registered delegates of IFIX only. So that is the email ID if you have any issues with registering. Next. Yeah. So this is the homepage of Ortho TV. You can type your query as Treasury in the search box and the Treasury will come up. Next. So this is all will be online. It is online currently also, and you can view this by logging in. Next. The videos are also available on the same page along with the infographics. Next. Next, Mandar. Yeah. So just go back one. So if you are already an Ortho TV member, your account will be already upgraded to IFIX special account, and you can log in and watch. There will be no difference to you in watching the other Ortho TV content as well as the Treasury. If you're not Ortho TV member, we have created accounts and upgraded it to IFIX special account, and you might have received emails or will receive email tonight. Please also check your spam folder if there is an issue. Next. If you have any issues with accessing Treasury, you can contact me directly also along with the email given earlier. Updates about the Treasury will be shared on the WhatsApp as well as on the Telegram group. Next. So thank you. And next, I think Swapnil will be speaking about the web quiz.
So I'm trying to upgrade him from delegate to panelist. If Ashok, you can do that. So people hypoglycemic and did not understand what Ashok was saying, we will be sending you a mail about this and also share the information on WhatsApp so you can check and access IFIX Treasury. Swapnil, can you just unmute Swapnil so that he can speak?
Yeah, Mandar, can you unshare your screen? I have a small presentation.
Yeah, absolutely. So Swapnil, welcome. Again, a young pediatric orthopedic surgeon, younger than me definitely, and who's secretary of Bombay Orthopedic Society. Mandar, you need to unshare your screen so that Swapnil, yeah. Swapnil, please share your screen to talk to people about IFICS quiz.
Yeah. Right. So IFICS is not only about learning, but it is also about feedback. And not only is it that we would want your feedback, but we would also want to understand what you are taking back from the live lectures. So what is this IFICS quiz? It is essentially a web quiz wherein each day, at the end of every day of the conference, we are going to be doing a cortical stimulation of each one of you. We would be sending a very short questionnaire. Don't worry, it's not a very long questionnaire at the end of each day. It's not an exam, so you need not worry about it. What is it all about? It's basically questions on your live talks. You need to answer the questionnaire, which will be in a Google form format, and send it to us as early as possible. All of you who have registered for the conference would have to answer all the questions to get your certificates. Where do you find the answers? You need to keep your eyes and ears open. If you do not know the answers, you can copy them from a textbook. You can go to Ortho TV and look at previous webinars. You can collaborate. And you can even, I guess, go back to the lecture and see what it is, or even the recorded lectures. How would you know if your answer is right? So we are planning to have a pre-conference curtain raiser where before we start the conference each day, we will have somebody from our team who will answer your questions and also give explanation to the same. What do you get other than a certificate? The overall winner will be announced at the validatory session. And those of you who are not able to make it, you will also gain a lot of experience, knowledge, and insight. So trust us, it's not a competition. It is learning by collaboration. Team IFICS consists of Dr. Avisha, Dr. Gaurav Gupta, Dr. Chintan Doshi, Dr. Sukalyan De, Dr. Binoti Seth, Dr. Sandeep Patwardhan, Dr. Arjun Dhavle, Dr. Mandar Agashe, and myself, Dr. Swapnil Kenny. This is the brainchild of the entire team of IFICS, which is Dr. Sandeep Patwardhan, Dr. Premal Naik, Dr. Shital Parikh, and Dr. Taral Nagda. And we urge all of you all to get ready for an experience of a lifetime to be adjudged as the IFICS Einstein. Thank you so much.
So is there any introductory quiz for today's sessions? Swapnil, are we going to have that?
We would definitely have one, and probably it would go to them tomorrow because they still have time. And probably before Saturday, they can send us the answers, and we'll try and answer that in the curtain raiser session.
So Saturday's session starts at 6:30 p.m. Indian Standard Time, but Swapnil will be here at 6:15 to answer the question to the quiz to the introductory session. So we request everyone to log in by 6:15 Indian Standard Time. First will be answers to the quiz, and at 6:30 sharp, IFICS Standard Time, we will start the lectures for the first session on facial injuries, which is going to be moderated by Dr. Premal Naik. So with that, good night, everybody. Professor Slongo, thanks for coming and joining us. Shital, thanks. And everyone, a goodbye, and see you back on Saturday. Thank you.
Bye.
Bye, guys. It was a great beginning. Good night.
Bye. Good night.